All right. Hi there. My name is Dr. Nick Ahrendt. I'm a psychiatry resident at the U of A Tucson. My poster presentation is titled Baby Steps to Attachment, and it was done in conjunction with Ali Pete, one of the other fourth year medical students. So, thank you for taking a look at our poster. Don't worry, I won't stay in this zoomed out version where there's tiny text. Just wanted to give a little bit of background of why Allison and I did this quality improvement project. We found that the introduction of attachment theory in our residency felt like it was a little bit late. We had our first attachment theory lecture about halfway through second year. And by that time, we had a ton of exposure to psychiatric patients. And really, we only got into the weeds of attachment during third year while working on therapy in our outpatient year. And it just seemed like such a critical theory that we would like to have it introduced later if possible. And this was just a pilot to see how the introduction of the content earlier in the residency could improve resident understanding. So I won't read through all of this, but essentially it says, attachment theory is important. Attachment theory, it's not well grasped usually by our younger psychiatric residents, and our hypothesis that the early introduction to the basics of attachment theory will improve the residents' understanding of their patients. We noted a primary goal of improving understanding of residents' patients. And the secondary aim or goal was to improve their understanding of attachment theory. So we kind of went for a bigger picture as our primary aim and then narrowed in for our secondary. As far as how the intervention was conducted, we surveyed both the PGY1s and the PGY2s before and after the intervention. And the intervention was about a 30-minute in-person lecture with a corresponding handout, which we'll talk about. The survey questions that we went through are in regards to our primary and secondary aims. The primary being, I have a well-rounded understanding of my patients. And this is a negative question. I have difficulty coming up with the psychological formulation of my patients. And then this other half is more in regards to attachment. I find patients with borderline personality disorder draining. I have a good understanding of attachment theory, and I know how to apply attachment theory to my patients' assessment and treatment plan. Of note, only half of the PGY2 psychiatry residents were present for the intervention. 2 of them were on night flow, 3 of them were out. This did serve to kind of cut the second year class in half. And while we considered just administering it to the second half on another date, like a month later, we decided to just let them be a control group and see what happened. So this is the intervention handout. I won't go through this in depth, but essentially we did a little bit of fill in the blank about what attachment theory is, and then the 4 basic types of attachment, which would be avoidant, secure, anxious, and disorganized. And some of the synonyms that are commonly thrown out, which are confusing, like avoidant versus dismissive or anxious versus preoccupied, and some case examples. These are the results of our study. As we noted, all the PGY1s were present. For intervention, 6 were present for the intervention, and that's the PGY2 active, and 5 were not, and that's the PGY2 controls. So in each of these, you'll see the 3 bars, blue being PGY1s, orange being the 2s that were active, and the gray being PGY2s that were controls. So in regards to these first 3 questions, really we found that overall, both the 1s and the 2s fell within a pretty similar range. In general, we saw the second years score a little bit better, but not more than a point apart. And this is on a 1 to 5 scale. So these are all within kind of the 1 point agree range. And really, there wasn't a big change overall post-intervention for any of these three groups. And really, the bigger changes we're seeing a little bit in the PGY2 controls. They apparently had a worse understanding of their patients after a 6-month period, or just that was by 1/2 of a point on average. And then on this third category, it seems that the control group found borderline patients more draining, and over time that reduced slightly. But since those were the controls, we didn't see that to be due to our intervention. And then more specifically on the secondary aim, we did show some improvements. Interestingly, the PGY1s and PGY2s were like packed in there in the same area of answering on the baseline at just below neutral, or halfway between neutral and disagree. And overall, they went up about a point or 3/4 of a point on regards to question 4. And we found that the PGY2s tended to improve a little bit more, including the PGY2 control, which I wouldn't expect. And in regards to the second question of applying attachment theory, that was even further down on the disagree. And overall, similarly, there was a 1/2 point to full point improvement with better improvements in the PGY2s. This is just looking at the statistical significance of the change, since it was within just kind of a 1 point change. As you can see here, most everything fell between the 0 and 1 range. The only place that we found statistical significance was in this question 5 among the PGY1s. This is likely relative to the small changes and also the limited group size. We didn't compare one group to another. Well, actually, we did those comparisons, but it wasn't statistically significant. Okay. Looking at conclusions, as I described at baseline, the residents didn't show differences between groups that were meaningful, and they all fell within 1 point of each other. And interestingly for me, all groups scored pretty low on the understanding and application of attachment theory. The average scores were closest to disagree on the Likert scale. To me, I think this is indication that it could be a way to bolster our education in residency. Regarding our primary aim, this brief intervention did not show efficacy based on the subjective reports in this 6-month period. They did show improvements in the second aim of improving the understanding of attachment theory. However, this improvement was seen across all groups regardless of receiving our targeted intervention. This could be because, the PGY2s progressed over 6 months. They also had one class where they did talk about attachment theory outside of our intervention, or maybe by intermingling within the group, they talked about attachment theory more commonly in their class. Only the PGY1s showed that statistical significance mentioned. And overall, this study suggests that our residents at baseline don't significantly differ in their understanding of patients and attachment theory, and that the understanding of attachment theory increased over the 6-month period, but it was regardless of the intervention. And while it does show that residents tended to disagree, that they have a good understanding of attachment theory, we didn't demonstrate an effective brief intervention to improve these measures. As far as future direction, something that I'd like to do and I plan on doing is just resurveying these PGY1s at a year later. So I kind of saw that they improved over 6 months. And if I see that they continue to improve over a 6-month period, maybe even go into the positive range on these questions 4 and 5. I think that would be adequate evidence to say that the intervention was beneficial, that they, grew beyond what their peers had that would be in a similar place if they hadn't done it. Because the PGY2s at early in their year, they were still in this kind of negative category. All right. Well, I'm open to any questions, and I will probably be wearing a different shirt. Thanks.